Hi, Anita Schneider here from Bangor Communications. I'm here at Sunnybrook Odette Cancer Center with Dr. Sunil Verma. We just got back from ASCO and he's going to discuss the non-small cell lung cancer session from Monday, June 4th.
The first presentation was looking at new EGFR targeted therapies, sort of the second generation of EGFR TKIs that were studied in the LUX-lung trial, presented at ASCO looking at afatinib versus platinum Pemetrexed in the first-line setting for EGFR mutation patients. And there was a striking benefit in favor of afatinib with PFS over the current chemotherapy standard of care for platinum and Pemetrexed. Overall, the difference was statistically significant, but what's even more interesting was patients who have the common deletions and the common mutations in EGFR, they were able to see a PFS of 13.6 months, which is above and beyond what we have seen with EGFR TKIs first generation with erlotinib or with gefitinib. So the question that comes up is afatinib superior to erlotinib and gefitinib? And is the toxicity that's seen with afatinib going to be something that we need to be aware of and manage? And can we manage the toxicity and garner the efficacy that we're seeing with afatinib over the other first generation TKIs? How do the two compare, i.e. the second generation versus the first generation, is going to be studied in a LUX-lung 7 trial. But overall, the results look quite promising, and we look forward to integrating afatinib as an option in the first-line treatment setting for patients with EGFR mutations. The second key presentation that was presented was the TAILOR trial by the Italian academic group. This was a trial evaluating whether erlotinib is superior to docetaxel for patients with EGFR mutation negative. So the question comes up is erlotinib actually efficacious in this setting, and is it superior to the chemotherapy? So the patients were randomized who are EGFR mutation negative to docetaxel or to erlotinib, and basically the results show that the docetaxel arm was superior to erlotinib. Now, even though this was a very well conducted trial and a good attempt to answer a very important question, there's some struggles that we have with interpreting the results because it was such a small sample size. The trial did not hit its accrual target, and it was an open label study and where clinicians knew what the mutational status was. So I think all those factors may contribute where the clinicians may say, well, this patient is mutation negative, is unlikely to respond. The data that we have is for PFS, and that may lead for the clinicians to sort of stop the drug earlier than expected. The primary endpoint for the study was overall survival, but this was not presented because the accrual numbers were quite small. And so that's another challenge about the statistical validity of the study when you don't have the OS data available, which is the primary endpoint, and only the secondary endpoint has been presented so far. Are the TKIs efficacious if they're mutation negative? Other trials have suggested that they are. So I think this trial is suggesting that chemotherapy is better, and I think we all suspect that chemotherapy is better. But if you have a mutation negative patient in front of us and we've exhausted our chemotherapy options, would we offer a TKI to them? I still would offer them TKI. It's just what this study shows that the chemotherapy is actually superior to TKI treatment if you're mutation negative. So the last set of trials that we'll be presenting or discussing today will be chemotherapy related. So the first trial was looking at whether there is a benefit of doublet chemotherapy or single agent chemotherapy in patients with performance status 2. So this was done by the Brazilian Latin American Cooperative Group and was presented at the ASCO meeting looking at Carboplatin Pemetrexed versus Pemetrexed alone in patients with PS2. And the results show that the platinum Pemetrexed arm was actually superior to Pemetrexed alone arm in PS2 patients with respect to PFS and respect to overall survival. Again, confirming that we should be considering platinum doublets for our PS2 patients as well, and this was a very well conducted study to really help highlight that. This also extends to our elderly patients where there is strong evidence to say when we can offer doublet therapy, we should be definitely going ahead and doublet therapy as it is shown to be superior to single agent treatment. The second trial that was presented along the chemotherapy spectrum was looking at maintenance Pemetrexed after somebody has had platinum Pemetrexed treatment. Here the patients had platinum Pemetrexed, and if they had response or stable disease, they were randomized to continued maintenance Pemetrexed or to stop the chemotherapy after just 4 cycles. And basically what this study showed was continued maintenance Pemetrexed is associated with improved overall survival. So this also suggests that we should be considering this approach for those patients who are receiving a good response or stable disease with initial platinum doublet, and this further adds to the benefit of maintenance chemotherapy in this setting. Now this trial is somewhat unique compared to the other maintenance trials where the same agent was continued on as was received in induction chemotherapy, but it really sort of suggests that maintaining on treatment for patients who are receiving a good response, at least with single agent which is well tolerated, would be of benefit. So this was a very confirmatory trial and also is practice changing.